Hello, everyone. I want to briefly go over a super important scenario. And the purpose of me doing this video is because I want you to remember what you are doing all the hard work for, why you're grinding it and working so hard in the ICU, and why you're doing the same when you're in CRNA school. So let's go ahead and dive in and look at this scenario. So I want you to pretend that you are by yourself. You are in a standalone center, a standalone office, and you are giving anesthesia. The other room has left, the other provider has left. It is literally just you by your lonesome. Okay. So here's a scenario. You have a 27-year-old female that the other team had done. So it wasn't even your patient, but you are there to finish your cases and you're also the recovering CRNA. So you have to stay and recover all the patients. Okay. So you have a 27-year-old female, super healthy, no past medical history at all. First time this person has had surgery, and surgery was super uneventful. It was like a 25-minute, 30-minute case, took off an ovarian cyst removal. That was about it. Nothing happened, right? Super chill. In the OR, she got 2 milligrams of Versed, milligram of Dilaudid. She got 4 milligrams of Zofran, 4 milligrams of Decadron, 30 milligrams of Rock, and then was reversed with 0.6 glycopyrrolate and 3.5 milligrams of neostigmine. In the PACU, this patient received 50 mics of fentanyl, and she got 800 mils of LR. Okay. So you are called to the recovery room, and the nurses are like, hey, her blood pressure literally just dropped out of nowhere. And you look, and the blood pressure is 120s, 130s, heart rate's in the 60s, but her blood pressure is now 70s over 40s. Patient appears clammy, super diaphoretic, coloring is just off, heart rate has remained 66, and the patient is super drowsy. So what do you do? So for me, my first thought is the patient bleeding, right? That's like the first place I go to is the patient bleeding? They had laparoscopic surgery. I should have said this was laparoscopic. So they had surgery. Are they bleeding, right? And so double check some things. Look at the dressings, press on the abdomen, any tender, any rigidness. In this case, any VABS bleeding, anything like that, right? So you're checking all the things. Okay, we've got that. Now we also have to kind of treat it a little bit. Well, let's see. Let's give her some fluids. Maybe she's, super dry, even though it's not that late in the day. It's not like it's 7 p.m. at night. But let's give her some fluids. Let's put her in Trendelenburg and let's see. So patient responds to everything. All is well. Okay, cool. But still, like, what else could be going on, right? Another thing you could think about. So one thing is, hypovolemia or like hemorrhage, essentially. Hypoglycemia is something you want to think about. So it doesn't really make sense. Not really a diabetic. I mean, potentially she could be, but what is it to just grab a quick blood sugar to see? Blood sugar was fine. Continuing to watch this patient, still super drowsy, and the blood pressure keeps falling. It responds to the fluids, then it kind of goes up. The patient tries to get up, the blood pressure falls again. Still not tacky. Maybe heart rate goes up to like, oh, let's fall off my chair, guys. Heart rate goes up to like about 80s. Okay, that's about it. Okay, heart rate's maybe going up like 20 points, not super tacky. Okay. Then it's like, let me look at the pupils. Did she maybe get more Narcan? Patient is still super just drowsy and out of it. So it's like, did she get too much Narcan? Did she get too much narcotics? Not really. I mean, a milligram of Dilaudid and some Versed, like not that much for a 27-year-old. However, some patients are just super sensitive. So you can give a little Narcan, right? So you can take a 0.4 milligram vial of Narcan. You can dump it into 10 cc's of saline, which is going to give you 40 mics per cc of Narcan. I would just give like 1 cc just to see, because Narcan is obviously, it's a dirty drug. Patient had surgery. They're going to have pain. I do not want to give too much Narcan. Then they're going to be super miserable, right? So give a little Narcan. Patient actually perks up a little bit. Blood pressure goes up. Patient's a little bit more alert. Okay, fine. Still, blood pressure continues to drop. Patient still continues to be drowsy. So why don't we try an EKG, right? So now we've tried like some Narcan. And then let's just check out the big guys, right? Like, let's just look and see, like, let me make sure, there's not some arrhythmia going on. Let me make sure there's no T changes, ST changes, etc. So do a quick EKG. Once again, it takes like 2 seconds. All right, EKG was super clean. Go back, look at the patient again. Any chest heaviness, any shortness of breath, Sure enough, patient's like, my chest feels heavy. I just don't feel right. Okay, does she have a PE? So now I'm like panicking, like, is there a PE? Not really like a test you can do by yourself, stand alone. So, and then patient, had on oxygen on at that point when the blood pressure fell, we did put the oxygen back on her. She was on 2 to 3 liters, 100%. And then when we took off oxygen, she's about like 94, 93%, super drowsy. So it's like, okay, patient's still clammy. My spidey sense is still just like going up. Like, what is even happening, right? So then you can do point of care hemoglobin. So it's really important when you're at these standalone places is what point of care test do you have? Obviously, usually pregnancy tests, blood sugar tests, but you can also do point of care hemoglobins. So did a hemoglobin. Guess what? It was 12. Now it's 8. Okay, that's a pretty significant drop. Now let's go make some phone calls. Belly is still soft, maybe a little tender, but like, she had surgery, so we'd expect it to be a little tender. So make a few phone calls. Do the unpopular thing is like nobody wants to ship a patient to an emergency room from a surgery center, right? That is literally not the goal. But however, spidey sense, we got to do it. So patient was sent to an ER via EMS paramedics. And ended up the next day, patient was bleeding, had a huge hematoma in their abdomen that was pressing on an artery. And yes, so remember, thighs, pelvis, and your abdomen are all places that patients can bleed into silently. You have a young, healthy patient, an uneventful surgery. You have a 20-second, like 25-minute surgery, right? Like, patient wasn't tacky. Nothing here is like glaringly obvious, but like something just wasn't right. She was young, she was healthy, so she was compensating very well, but just didn't quite, but still wasn't really waking up, and something just seemed to be off, right? So I want to just share this as a reminder that this job is way more than just your knowledge and looking good and being awesome at intubation and all the things. It's actually the application of everything. It's your ability to think, your ability to troubleshoot, your ability to communicate, your ability to direct the room and figure out what needs to be ordered and what steps, how to do it. And you only get good at this, number one, by being really good at your job in the ICU. Excellent nurses make excellent CRNAs, and also making your CRNA clinicals count. I don't care if you like your preceptor or if they like you, squeeze the life out of your experiences and build off knowledge, even if you're just observing something. Ask questions, like watch every motion someone does. How are they communicating with the doc? What are they thinking? What is happening, right? I just recorded a podcast that you can check out. It's episode 7 that I further go into kind of working at places, when you graduate and stuff like that, but definitely be sure to take a listen to it. But this job becoming a CRNA starts with having a solid nursing foundation. And then when you get into clinical, not making clinical mean anything about you and your ego, but more about the value you can provide and the future lives that you're going to advocate for and save when you are the CRNA at the head of the bed. So that's what counts, and that's what matters. All right. Have a freaking awesome day, y'all. Work hard. Hurry up and come join me in the ORs at the head of the bed, because we need good providers out there. Okay. See you next time.